And now I would like to invite Dr. Tillal Eldabi to give his talk titled Simulation of Emergency Department in GCC. Dr. Tillal, please take the floor.
Okay, we had a good introduction early on by Professor Mansour regarding communication between academia and industry. And that's followed by an interesting keynote on the use of data and simulation in healthcare. So what I'm trying to do is to give you an example of both, which is collaboration between a university and industry, and in the same time, it's on the use of simulation in healthcare. So I'm calling it an introductory case because it's just a very small step trying to show you an example of how you can use some of the knowledge, academic knowledge, in a real case it's in the GCC, but you know what I mean. I'm not allowed to say any details about this case, but I can tell you about it and you will understand between the lines. Up to this point, please do not put this on the YouTube. You can start from this point. Okay. So the talk plan, first of all, why do we need simulation and when to simulate? After that, I'll talk about some specific components of discrete event simulation. David was talking about 3 types of simulation early on: agent-based simulation, discrete event simulation, and system dynamics. My specialty is discrete event simulation, even though recently I've been working on hybridization between the 3 methods, but my heart and my experience is actually in discrete event simulation. So I don't know anything about system dynamics, a little bit, and some agents. So I collaborate with others who have the knowledge in those techniques, and we work together. So we use simulation of an accident and emergency department to just give you an example of the use of simulation, some typical KPIs, and I'll talk about the case, obviously followed by the lessons learned. Okay. Now, preparing for disaster. This is here from Bahrain a few years ago. And there was a drill that was done in the airport here. And then they brought some people, real people, to simulate a disaster. So if there is if something happens, a fire, explosion of some sort, how do you actually respond to that? So the best way people usually do is to bring some people and play an act in that environment to see how the system behaves. So I will keep that picture aside, and I will talk about why do we actually need simulation. And people who are working in critical areas, they do disaster drills a lot, but that is actually very expensive. Sometimes you have to burn down a building to show how things behave. So what we try to do is to simulate that instead of going through the whole direct experiment, and that will save a lot of money. So the benefits of using simulation is to study an experiment with the internal interactions of complex systems. Sometimes people use some mathematical models to describe a system, but some of these models oversee or cannot identify some of the internal interactions of the system, and to observe the effect of alterations. You know, David mentioned this a lot. If you want to make a change, you want to see what will be the outcome of your change. And sometimes you will see a lot of decisions being made, either at policy level or operational level. People just make decisions without really thinking about the impact of these decisions. So simulation is used to look at that. And you can actually, you are being able to experiment with the system. So the system is not built. this university is planning to build a new campus somewhere here in Bahrain. So sometimes you want to look at how you experiment with the flow of the students, evacuations, some of these aspects. The system, the campus, the building doesn't exist, but you can actually play with different variables using simulation and see how it will behave and how it will respond to that. Now, let's talk about discrete event simulation. It's a very simple approach to life. So it's made of three, like any other modeling approach, it has three components: input, modeling, and output. So imagine that you have a system where things coming in, these dots, blue dots, could be people, could be products, could be pieces of information. They come in from outside. We call them temporary entities. They come, they are processed, or they join a queue waiting to be processed, and then they leave the system. In the system, there are some permanent entities. We call them resources. So the resources, they process the temporary entities before they go out. Coming to the system, they follow some statistical rates and distributions, arrival rates, and so on. So that will be part of the input. How long they take to process, that's also follow some statistical distribution. The output for that will be waiting times, how long something is waiting. For example, if you want to model the causeway, it's a very complicated process. How many tolls do you want to open, and so on. And it could model different types of traffics. Utilization rate. So sometimes you can reduce the waiting times to 0, but you may have low utilization rate. So you buy machines, but these machines are idle, you can't read them. And then time in process. How long did they take? So these are the main measures of performance that you use. And one important element is that all of these things, they go through time. And that's the most important thing. If you think of statistical techniques to come up with an answer, is a snapshot, is a picture, the simulation is going through different times. So now, emergency departments, and David was talking about that, is one of the most simulated systems in the world because they are compact, but in the same time, they are very complex. And nobody was able to find a specific solution for them because they are wicked. And it's a wicked problem. By a wicked problem, I mean you find a solution, and this solution creates 10 other problems. So, and their biggest problem is, if you look at an accident, an emergency, or an emergency department, it's very simple. They have 4 or 5 departments or sub-departments. They classify patients accordingly, but they are susceptible to overcrowding very quickly. So this is a typical picture or floor plan of an accident emergency department where people come in and they are distributed to different rooms according to the level of their trauma. The main measures of performance or key performance indicators are length of stay in the system, the waiting time, treatment time, and staff utilization. So if you want to assess the quality of accident emergency department, these are the main aspects. So let's look at an example. And in this example, I'm going to show you conceptual model. The categories of the patients, arrival rate, resources location, and the hospital disaster plan. So in this example, we are going to look at modeling an accident and emergency department preparedness for disaster. Now, this accident emergency, it's not very far from here. They don't have a lot of overcrowding, but we want to see whether they are actually ready to meet the demands of a sudden disaster. Similar to the drill that I showed in the beginning, but in a simulated fashion. So, this is the patient flow as people come in. I'm not going to ask you to read that, but usually when you start your model, you start with a skeleton. So we went and visited those people, the stakeholders, the owners of that department, a couple of times to come up with a skeleton of the system. Before you go into the model, you need to have an understanding of the basic and the main aspects, components of your system. So now they divide the patients into 5 categories. So you have the red patients, what we call L1. These are the people who potentially going to die any minute now. They're coming with a heart attack, cardiac arrest, very severe head injury, neck problem. They're actually about to die. The yellow are people with broken ribs, life-threatening problems, trauma, but they can live for a day or two, and they can live for longer if you actually do something about them. The yellow one are the normal, you have broken bones, but in the limbs maybe, in a non-life-threatening area. Then you get the green, people have blood, but it's not life-threatening, and there's no internal injury. And the blue one, who are people who, if somebody have a cough or cold, they go to the accident emergency department to get aspirin. These are the ones who don't really need care. And to be honest, the department that we have been working with, they don't have a lot of waiting time issues, just like accident and emergency departments in the UK, and they don't have that pressure, but they are still suffering from a lot of blue people coming to them. And they usually tell, it's very difficult for them to tell them, oh, you don't need accident emergency department, you need to go to the health center. I don't understand why you're saying this to them. You are depriving them from their right of treatment. But that is not what we have looked at here. So these are the different distributions. So usually 1% of the patient in the red, 2% yellow, orange, and then 43% yellow, 51% green, and 3% blue. So it's manageable, basically, because there are not a lot of problems. Now, we have looked at arrival rates, and these are the different arrival rates. It's not the same. So, for example, between midnight to 1 o'clock in the morning, people come every 4 minutes. And then between 1 o'clock in the morning until 8 o'clock in the morning, they come every 30 minutes. And then between 8 o'clock in the morning until 1 p.m., it's every 5 minutes, and so on. You can see a pattern here. So, for example, between 1 o'clock in the morning until 8 o'clock in the morning, people are sleeping, not many accidents. And even if there is a problem, people will say, okay, I'll go tomorrow. And this is increased, and usually this is the busiest time, between 8 o'clock in the morning until 1 o'clock. This is the busiest time because everybody, they're planning to go to the accident emergency, they go at that time. And I have highlighted this in red because something is going to happen here that I want you to remember this time that people come between 1 o'clock in the morning until 8 every 13 minutes. So this is the model as we developed it. and we used Simulate, our beloved Simulate. So people coming in, I'm going to show you a model running later, but slightly simpler than this one. So you have people coming, they go to the registration, they are triage. In the triage, they may actually be sent to the health center or the rest of the hospital, or they're distributed to the green, yellow, orange, or red area, and these are the treatment area. Now, it doesn't look physically like this, but this is from a logical perspective. And then they're either discharged or admitted to the hospital, and everybody in the end goes out of the system. These are the resources we use: the admin, the triage nurse, the major nurse, the yellow nurse, the doctor, the major doctor, the beds. So these are the resources that you need to process the patients as they come in. So this is the base model. Now, I tried to do something I hope it works. So this is a much simpler model. And if you want to run it, you press run. And you can see people coming in. These are little people coming in with problems, and they say they go to registration. And once, if there is nobody in the registration, they go to triage, and then in the triage, the nurse will distribute them according to their condition. So they could be a yellow patient, or they could be an orange patient, or a red patient. Okay. Now, obviously, they may also be green patient, or could be blue patient, and okay, go away now, we don't want you. Is this it? Where is it? Okay, we're here. Now, obviously, you can experiment with the system, and then you need to know whether your base model is similar to the existing system or not. So we run the model, and then we realize it's actually visually valid in the sense that it matches this. The blue one is the actual number of patients, and the brown is actually the most simulated patients, and you can see it's actually matching it by magic. Right. So we are happy with our base model. Now we want to simulate a disaster. And how do you simulate a disaster? So what they decided, they're going to be a bus crash. And the bus crash is going to take place at 1 o'clock in the morning. It's highly unlikely, but let's say that it happens. And the people will come in, and ambulance will go to the bus crash site, and they'll go and pick up the patients. There are a lot of patients, and the patients will come to the hospital. And that's the in-stream of patients starting at 1 a.m. until 2:20. So if you remember in the table, the people are coming every 13 minutes. So we made them come every 4 minutes. In that 1 hour and 20 minutes. And the total number increased from 218 to 278 for that particular time. So this visually, this is the original rate. And on the right, this is the accident rate. So the red patients increased by 5%, and the orange patient increased by 5%. And the rest almost stayed the same. All you need to do is just increase red patient and orange patients, and that's what happens. So when we introduce the bus crash without doing anything, we have the red patients delayed, or the average length of stay in the system is increased by 89%, almost 90%, almost double. And the orange is decreased by 2.3%. And then you have the Yellow patients increased by almost 100%, and this one, the green, is increased by 142%. Why? Because when you have more red patients, they are all going to die, and you have orange patients. What happens is the effort is now shifted to the people who are going to die, and the green and the yellow, they're okay, we can look after them later, so their length of stay is increased. So that tells you that our model is doing something great. Now, and obviously, the red patients, they stay for longer because they're either going to be staying in bed or dying. There's no other way about it. The orange are the ones we really can do something about them. That's why you see that they decreased their waiting. So, the hospital disaster plan, obviously that was the original work. So how do you prepare for that? What they do is they eliminate they take out the green, they stop looking after green, and we want to reduce the admission time. This is the existing hospital disaster plan. So the outcome of that is the reduction is, this is the delay without doing anything. This delay is reduced by 38%, and for the orange is even more, by 20%. So, in the model, we said, let's add a couple of doctors to that. So we realized that we pushed it even more. By adding 2 doctors, we pushed it even more lower. Obviously, there's no change for the green because we stopped green and blue patients coming to the system. We're now looking after the red, orange, and yellow. So that's what we have here. So you have the actual system, the simulated system, the simulated system with the disaster. You can see, boom, the red going up and the yellow. And then the simulated system with the current hospital disaster plan, and the simulated system with our added plan to see that even the current disaster plan, although it's working, it will improve the situation. We have just discussed with them that if you actually introduce a couple of doctors, you can actually improve it even better. By the way, if you increase 2 doctors, you improve the situation. That doesn't mean if you increase 3 doctors, it's going to improve the situation, because you may have a third doctor, because with a doctor you need some nurses, you need some beds, so you can have a third doctor sitting doing nothing because the system reached saturation from a doctor's point of view. Now, I think I have talked about this. A simple simulation model can actually, this is not very sophisticated. It was very simple, but can provide a number of issues in terms of the sustainability of the system. And it is quite promising in terms of providing better information if you have a drill exercise. And the data is an issue, but I think from what David was talking earlier, things like data farming in this environment, because there's general data paucity, and data farming can actually work even more for